Good evening, everyone, and welcome to tonight's Grand Rounds. It's my pleasure to introduce and reintroduce my consultant colleague and pediatric ENT surgeon, Ms. Lily Jablenska, who's going to be talking us through some multidisciplinary challenges regarding pediatric tracheostomies.
So thank you very much for introducing me. My name is Lily Jablenska. As Ishan said, I'm one of the pediatric ENT consultants, and I'm a relatively new consultant. I wanted to talk about pediatric tracheostomies, and particularly about a topic that's increasingly discussed much more, about the multidisciplinary challenges, and just to sort of give an overview of the topic. And part of the reason why I wanted to talk about it is because pediatric tracheostomy is very challenging. When we start our training as registrars and new consultants, one of the main focuses of pediatric tracheostomy is the technical aspects of how to do it, the trauma of doing it, making sure that you technically execute everything properly. But as I've gone into my consultant career, much more, I'm thinking about sort of the immediate and long-term challenges that I'm going to face looking after the patients. So just in terms of a very brief overview of the topic, so talking about pediatric tracheostomies, indications, and the differences between pediatric and adult airways, tracheostomy formation, and the tracheostomies themselves, the complications, and also about who actually ends up looking after a child with a tracheostomy and the challenges from different people's perspective. So hopefully it will be a little bit of a different talk and quite interesting for most, if not all of you. And then some learning points from me. And at the end, it will be really interesting to hear what your views are, what challenges you find, and things that you've experienced as well. So just in terms of the definition, and the reason why I've put it there is because quite obviously it looks like a very, very straightforward, simple definition. A tracheostomy is a surgical opening in the front of the neck to permit for a tube to be inserted and allow passage of air. And it's such a simple, straightforward definition, and it doesn't encapsulate how complex a surgical tracheostomy is, in particular the pediatric tracheostomy. It is so complex in terms of the thinking pre-tracheostomy, the procedure itself, but also the immediate and long-term challenges, as I mentioned. So just thinking about the indication for a pediatric tracheostomy, there are three main indications. So ventilator support, which is either actual or anticipated, bronchopulmonary airway secretion management, as well as the fixed upper airway obstructions, which the tracheostomy can bypass. And these include things like subglottic stenosis, bilateral vocal cord palsy, tumors, congenital airway malformations, and associated syndromes. So thinking about the pediatric airway, it's really important to compare the two. And the reason for that is because that is the reason why there are changes in terms of how we do the procedure and the long-term challenges. So the airway is much smaller in the pediatric patient. The average diameter of the subglottis in a fully term baby is 3.5 millimeters, which is teeny tiny when you think about it. And in a preterm infant, that's even smaller. The adolescent, 7 millimeters, so double that. And in an adult, 10 to 14 millimeters. The head of the infant is much larger and with a more prominent occiput, so it gives the different head position. There's a larger tongue, which in the context of the oropharynx and the oral cavity is much bigger, it takes up much more space. The infant hyoid and larynx are situated higher than the adult, and the vocal cords are shorter and concave compared to the adults that are more horizontal. The epiglottis is shorter and omega shaped, and cartilage is soft and less prominent. So when you actually do the tracheostomy, the cartilage rings are much more difficult to feel, and that makes the operation more challenging, particularly when you're doing it as an emergency. And also the lower airways are less developed in an infant. So when thinking about the tracheostomy formation, the first thing to say is that with all of our children who end up having a tracheostomy, we aim to do an MLB beforehand to assess the airway, to be able to fully understand what is going on and whether there's one abnormality or multiple abnormalities. And then in terms of positioning, as you know, is important both for adults and pediatric patients. But in the way that we position the children, we overextend their neck, and we tape their chin to the table so that their chin is out of the way, the neck exposure is optimized. In terms of the procedure itself, we make an incision halfway between the cricoid and the sternal notch, exactly the same. We remove the pretracheal fat, which again is a difference between the adult and pediatric tracheostomy. And we put stay sutures once we are on trachea, stay sutures before we make the vertical tracheal incision. The stay sutures stay there for the week or until the first tracheostomy tube change is performed. And they are safety feature, because if the tracheostomy were to dislodge or come out, just pulling on the sutures on either side of the trachea means that we open the tracheostomy lumen up, and it makes it safer for the tracheostomy to be reinserted. We also put maturation sutures, which again is different to the adult tracheostomy, and that is a suture between the skin and the trachea itself. And that basically is a safety measure to make the lumen of the tracheostoma ready and open in case there is a dislodgement. So it's a safety measure. And also the tracheostomy tapes, there's a lot more thinking and care taken on when doing the tracheostomy twill tapes at the end of the procedure, making sure that the tracheostomy is firmly in place and is not likely to dislodge. And as with the adults, we also confirm the positioning, we flexoscope to make sure the length of the tracheostomy tube is adequate and it's in the correct place. And one further thing that is, again, similar but different is the suction length. We are very careful about measuring the suction length as we put the tracheostomy tube in to make sure that that length is appropriate, it's not too long, and to minimize any chance of traumatizing the lower trachea and causing any granulation tissue. So again, there's a difference between a pediatric and adult tracheostomy tubes. And the reason for talking about those things is because they present different challenges. And most of you hopefully would have come across adult tracheostomies, if not pediatric ones. But coming across pediatric tracheostomies is actually not that frequent. Certainly before I came to Evelina as a fellow, I hadn't seen many. I certainly hadn't manipulated or done very much, and I hadn't really done any pediatric tracheostomies independently. So it was something very, very new to me, and it was something that was certainly scary to think about. So thinking about the tubes, they're much smaller. There are neonatal and pediatric sizes. And the length varies, but the diameter is the same for the same size tubes, the neonatal and pediatrics. There's no inner cannula for the pediatric neonatal tubes, and there's no fenestrated tubes as well. So that is quite different between the adult and the pediatric. Most pediatric tubes are cuffless, so we sometimes put cuff tubes for those requiring ventilations. But if they don't require ventilation or they can ventilate adequately with a cuffless tube, we prefer to use a cuffless one. The cuff tubes don't prevent any aspiration. That's really important to know. So in the adults, we often say that they prevent secretions from going down. In the pediatrics, that's not the case. They can bypass the cuff. So that's not an indication to put a cuff tube in either. And then finally, the size of the tube will increase as the child grows. And that's important to be aware of, not just because we think about upsizing the child when we do our routine MLBs after the tube is in, but also because the problems and challenges and complications that can come with the tube that is too small for a child, you need to be aware of those, like a tube coming out and the child being able to cough it out, constant rubbing, again, problems with ventilation if they're on a ventilator and they have a too small a tube. So these things have to be considered, and the size of the tube has to be the appropriate size for the age and the size of the child. And this is the Great Ormond Street Hospital chart for pediatric airways, and I certainly find it very useful on a day-to-day basis, both to choose the appropriate pediatric tracheostomy tube size. The tube type is chosen based on mainly on what's available to you, but the one that we use at Evelina is the Bivona Flex 10, and you use the tube type and the age of the child to choose the appropriate size. But of course, you also have to assess and see if that is appropriate. Some children require custom-made tubes. in certain situations. So thinking about complications from a tracheostomy point of view, pediatric tracheostomy still hold huge morbidity and mortality. The mortality is still 10 to 20% due to the significant comorbidities that come with needing a tracheostomy. So it's important to be aware of those. So early complications being bleeding, surgical emphysema, damage to the lateral structures, tube dislodgement, pressure necrosis, mucus plugs, respiratory arrest, pulmonary edema, and the more late ones, bleeding, tube problems, mucus plugs, excessive crusting. One of the things is cosmesis. So initially cosmesis, I would say, is much more important to the parents and the carers because it totally changes the way their child looks. But as the child grows and goes into older child in teenage years and early adulthood, cosmesis becomes much more of an important factor. So as you can see my terribly drawn picture, hopefully, this is a picture encapsulating who cares for a child with a tracheostomy. As you can see, the child is in the middle and there's lots and lots of people that are involved. The parents or parents, carer or carers, the surgeon, obviously the ENT surgeon and the anaesthetist who have done the tracheostomy. One of the really important members of the team is the Tracheostomy ENT CNS part of the team, who I'll talk about in a little bit more detail later. Social worker or general practitioner, a community team in itself with a pediatrician, speech and language therapist, the school and nursery. So lots and lots of people. And the reason why I think it's important to think about that is when we first focus on tracheostomy, it's very much about the practical, as I said, but there is just so much more to think about. It's important to think of the child medically and socially, developmentally. And so all those people are really, really important to think about. So obviously, what I didn't want is to talk about an individual person, but I've picked a few people to talk about. So the first member of the MDT, and MDT, we normally think about a healthcare multidisciplinary team, but I think in this situation, parents are really, really important. They are the absolute mainstay person who stays with the child. They know how they were beforehand, what they're like. They take care of them day to day. So I think they're a really important member of the team. So in terms of the challenges that they experience pre-insertion, they're thinking about what is best for their child. Is a tracheostomy the right decision? Is it better to wait? Could there be an alternative? They're trying to understand and increase their understanding of what tracheostomy will involve. And that is often difficult because as I said, it's much more than just the tube and the neck. They have to consent to the procedure, and consenting is often difficult because the complications can involve morbidities as well as mortality. And depending, there's not that much time, although pediatric tracheostomies are planned, there's not always a lot of time to allow patients and parents to think about the consent process. Post-procedure care and training, so they're involved in looking after the tracheostomy in terms of the stoma, the tube change, the tracheostomy tapes, as well as looking after the child as a whole. And then discharging home is quite a big challenge, thinking about their medical needs, their social implications of going home, their family life back home, how they will slot back into the community. So that's usually a big undertaking. And they will often involve a lot of equipment. It may even involve changing of the house because there are certain conditions that a child with a tracheostomy has to have. The long-term follow-up, so I mentioned that we do microlaryngobronchoscopy. So in children who have tracheostomies, they come to clinics, they come to theatre, they have MLBs on a different frequency basis, so 3 months, 6 months, a year, depending on their etiology of why they needed the tracheostomy, but it involves a regular contact with the hospital and the team. For the parents, it has a huge psychosocial impact, and as I mentioned, that's something that's people becoming increasingly more aware and publishing a lot more about it. And managing the level of uncertainty in a child who has a tracheostomy, there is huge amount of uncertainty about the next day, the next week, when to go home, when the tracheostomy, how long it's going to stay in, when it will come out, will it come out? And as healthcare professionals, it's our job to manage those levels of uncertainty and give some fixed ideas, at least, of kind of regular MLBs, regular contact, access to care, so that parents don't feel that there's just a kind of an open space with no detail. I'm going to play you a video from the National Tracheostomy Safety Project, which was started in Manchester, and it's just really a minute long, just to give you an idea of how parents feel about tracheostomies. So I'll just play that for you.
The day I was told, we were taken into a little room by one of the surgeons and his registrar, and they sat us down and told us the reason for Thomas needing his tracheostomy. I knew there was issues with Thomas, but I never expected that.
In Molly's first year, it was a vicious circle of intensive care, HDU, on the vent for long periods of time. ENT respiratory then suggested that a trachea would be the best option for Molly. I'll be honest, I had panic attacks thinking about it, and I didn't sleep.
The only thing we knew about a tracheostomy when it was first suggested was that it was obviously a hole in the throat, which we found extremely worrying. Actually seeing the tracheostomy, and it wasn't as bad as we'd expected. It was actually quite small. We've seen a noticeable difference in everything, including, his pallor, his colour's much better, his breathing is a lot quieter.
The tracheostomy has been an absolute godsend in terms of her development. It's led to her gaining weight, and the fact that she's gaining weight, then she has more energy, and then everything that brings. It was the best thing ever.
The tracheostomy has made a massive difference to our life, and it's a better quality of life for your child. At first, I couldn't see that. I never expected to be saying this now, that, yeah, the tracheostomy is a good.
Okay, that's my editing skills, not great. So the next people that I wanted to talk about in terms of their input and as a multidisciplinary team and the challenges that they encounter, the tracheostomy clinical nurse specialists, and they play an absolutely huge role in managing the tracheostomy, in managing the children and the families who have tracheostomies. So pre-insertion, they have huge contact with the parent in terms of trying to educate them and make them understand as much as possible what the implications of having a tracheostomy is. They try to form a rapport with the patient, with the parent, and often it's very difficult because the parents don't always want to have all the information. They're not always receptive or ready to have that information. So again, we're guided by, how the parents are doing, if they're ready to have that discussion, but they're always there for contact, and it provides a great continuity in terms of that pre-tracheostomy input. For me, certainly they help in selecting the right tubes, making sure that there is enough for the operating theatre, and preparing the box, which you can see on the side, with all the equipment that's necessary immediately after the operation, including the spare tubes and so on. So again, that's something that's hugely important. They're involved in the daily care for the tracheostomy, so they look after the tapes and the tubes. They do a daily ward round to make sure that the tubes are in the right place and so on, and do the first tracheostomy change, as well as training the parents in terms of the daily care of the tracheostomy, and ensure that their supplies are available to the ward, and once the child is discharged home, that they're available at home. They support the ward staff and the parents and in the community. So they provide support as well as education. So they provide formal lectures and workshops. And they're also important when there is the regular monitoring. So either clinics or when they come for MLBs, they reassess the patients, they troubleshoot, and they're also the emergency contact for the patient and the parent. In terms of decannulation, they run a decannulation program. So once a decision has been made that a child is ready for decannulation, they will arrange for sleep studies and for the admission and they're very, very closely involved in decannulating the child. And finally, updating any tracheostomy related protocols. So again, that's something that requires constant work. We're constantly evolving and improving and trying to make things better. And so those protocols are also changing and updating. The ENT surgeon. So obviously as an ENT surgeon, we have quite a big role in terms of making the decision for the tracheostomy, but also placing it and looking after the child long term. So pre-tracheostomy, there's always difficult decisions regarding the indications and timing for the tracheostomy. Thankfully, that's not very often a unilateral decision. It's a multidisciplinary decision, either within the ENT team or within the wider hospital team, because these children are often complex, and that makes the decision for the tracheostomy easier. But sometimes it is difficult. In children, for example, you have bilateral vocal cord palsies or Pierre-Robin, or a condition that is not they're not constantly unwell, or they have just periods of being unwell. There sometimes isn't that clarity of putting a tracheostomy straight away. So sometimes it's a period of observation, and that can be very challenging to know exactly when the right time to put a tracheostomy is. The tracheostomy insertion, as I said, it is challenging, particularly in the small babies with limited sort of reserve. So it is a challenging procedure. The tube choice can be difficult to sometimes know exactly what the appropriate tube choice is for the child. So there's, as I mentioned, the bivolar, the Shiley, and there's lots of different, the tracho, and sometimes you have to make a choice of what is best for the patient, as well as what is available. And then securing the tube at the time of the tracheostomy insertion, as I say, it's a little bit of an art, making sure that you do it properly. And thankfully, if you don't do it properly, the tracheostomy nurses will always come and help out. So post-tracheostomy insertion management, the challenges are both immediate and long-term. So making sure you look after the patient on a day-to-day basis. We're generally very focused on the tracheostomies. And so we work in a multidisciplinary team with our paediatrician colleagues, with the respiratory team. But as I say, as I've kind of gone along in my consultant career, the long-term implications and management really starting to make me think about those challenges that will come along. The long-term monitoring and MLBs, you know, how frequent do you do MLBs? Of course, it depends on the etiology. Is it 3 months or 6 months or a year? And just trying to find that balance of making sure the child in the tracheostomy is safe, but not bringing them in too much and putting them through too many anesthetics. Managing complications, both with the tracheostomy being in place, so granulation tissue, suprastomal collapse, and also monitoring the process of the underlying condition that has led to the tracheostomy. And then thinking about decannulation, when children are ready for decannulation, that sometimes it can be a challenging decision of when to decan and when not to decan, when to wait. And if a child were to try and fail, what happens afterwards? So those would be things like, would they require a long-term, lifelong tracheostomy? Would they require some level of airway reconstruction? What that would be, and the level of decision-making in terms of what that reconstruction would be and where that should take place. So at every stage, there are challenges of thinking about a child with a tracheostomy. And as an ENT surgeon, those challenges seem to continue until the child is decannulated. And even afterwards, if a tracheostomy stoma has not closed, again, that can be a challenge in terms of deciding when to close the stoma, how to close it, either by primary closure or just freshening the trachea or tracheostomy stoma edges. You know, there are all sorts of decisions that need to be made. So I'm very briefly going to speak about speech and language therapists, although they play an absolutely huge role in management of children with tracheostomies. And the reason for that is because one of my esteemed colleagues spoke very recently about the role of speech and language therapy in children with airway problems. And she spoke about all of those things. So I would urge you to watch her presentation on that, which will be in a lot more detail. But the speech and language therapists are involved with children who have tracheostomies, either before the tracheostomy or certainly immediately afterwards, in terms of ensuring they have a safe swallow, and how to slowly progress onto oral swallowing if that is possible, or if they need a gastrostomy tube. They're involved in voice and making sure that the child is able to voice, and to decide on speaking vowels, whether that's appropriate or not, and also speech and language therapy, speech and language and communication. That's something that parents often worry about. Would they be able to speak? Would they be able to communicate? And having a fantastic speech and language therapy is really, really helpful in terms of managing that aspect and making sure the child develops normally. And in our department, certainly we have a multidisciplinary team, speech and language therapy outpatient clinics with our ENT CNSs, where hopefully all of the concerns are addressed at those clinics. So just from my point of view, just to talk about a few learning points. So just the surgical tracheostomy insertion is a tiny part of the whole picture. It's important to think about the child as an individual, but also the family that they come from and they're going to. And so it's important to have a holistic approach to managing these children. It's important to remember the potential implications as well as complications of inserting a tracheostomy. And absolutely MDT approach. There is no other way. And if you could look at papers, increasingly, that's something that's being highlighted as the gold standard and working towards. There's continued improved care and support and education to minimize any potential clinical risk and improve the quality of life. And quality of life is something that is looked into more and more as we go along, not just for the child, but for the family as well. And continued education for staff. So I think making sure that we continue to learn, that continue to improve, and to try and minimize the morbidity and mortality associated with tracheostomies, and to make the experience of having a tracheostomy as positive as possible for the child and the parents. And there's a few papers that I think are brilliant to have a read, just in terms of looking at paediatric tracheostomies. So that's the end of my presentation. Thank you very much. So
there's one question that's just come through to the chat, asking if you could please expand more on the conditions and frequency of MLB.
So that's something that I certainly find a challenge to know exactly how frequently. So I would say in children who have, the initial MLB, I think, should be 3 to 6 months after the initial tracheostomy. And then beyond that, it depends on what you find. So if the child if you found granulation tissue, significant granulation tissue at the time of the procedure, if depending on the size of the child, so if they're very, very small, you would want to do the MLBs more frequently. If the child has had a long-term tracheostomy, is an older, and the tracheostomy looks, there are no complications above or below the tracheostomy, I would then expand that time to an annual time. But obviously it needs to be taken by case basis. It's very difficult there is no specific set, or you should do this if it's 3 months, or you should do this 6 months, or do this on an annual basis. And I think experience is the thing actually that ultimately guides you in terms of how you make those decisions. And children who are on ventilators, for example, who require ventilation, they may require more frequent MLBs because their ventilator settings can be affected. They may require upsize more frequently. So again, just working closely with the respiratory team in terms of finding out when that time needs to be.
Brilliant. The next question that's come through is about decannulation. How do you work a child up to assess if they can be decannulated? Some of the American texts suggest a sleep study first prior to the decannulation process. Is that also similar in the UK?
So I think one of the things, so everybody, I think, certainly who deals with pediatric tracheostomies is working on a decannulation protocol and working on a more united decannulation protocol. Usually before you think about decannulation, you would do an MLB probably 6 weeks before deciding. So once you've done the MLB 6 weeks after that. If you think the child is ready for a decan, you would then book them for the decan. You would normally do a sleep study beforehand, absolutely. And we would normally do a sleep study once the child is decant to make sure that their carbon dioxide hasn't raised significantly. And the timing is different in different places. They can vary between 3 and 4 days, so it's much longer than in adults. They're brought in and they're capped usually for 6 hours, 12 hours, 24 hours, and then they are decanned, and normally they stay 24 hours after they've had a normal sleep study, after they've been decannulated as well, but that varies.
The next question that we've got is from a previous Evelina fellow from Greece, Olga Ziara, and she's asked about tracheocutaneous fistula and how long would you wait before closure and what technique would you use?
So again, something I think that is challenging to make a decision on. I think if they are, so I think a minimum of 6 months to a year after decan before thinking about closing it. And also you would want to make sure that they're not using the stoma to breathe through it. So you would want to do a sleep study beforehand to make sure that when it's closed and not used, that they're still oxygenating appropriately and they don't have raised CO2. So you would wait a minimum of 6, because it can close spontaneously by itself without needing anything. And then technique wise, I'm aware of 2 main techniques. One is primary closure, so cutting the trachea, cutting around the trachea, the rim of the trachea, and then suturing it with closed and then multi-layer closure above it. Or the other technique is just to literally freshen the edges of the skin and the trachea and just to cover it. The downside, I think, of primary closure is that it obviously, when you close it, it narrows the trachea a little bit further. And so in very little children, it's obviously a worry that they may narrow their airway significantly. So I think more so people are using the second technique that I mentioned, which is it's much more straightforward and it just allows the area to heal itself, heal by itself.
The next question that we've got is from Wasim Modak, who is asking that would you suggest a tracheoscopy and bronchoscopy at the time of follow-up MLBs as well?
Tracheoscopy and
bronchoscopy. So,
I mean, I think maybe, I'm not sure. I think people probably use different terms. MLB stands for microlaryngobronchoscopy, and that is an endoscopy all the way down to carina. So, yeah, absolutely assess the trachea and down to the bronchi, or to the carina anyway. Yes, I would, yeah, as part of the assessment.
Okay. The next question is from Ali, who's said that you've given a very excellent talk, Lily. He's asking about how would you manage a granulation tissue inferior to the tip of the tracheostomy tube, and whether there's any role for topical betnosol drops.
So I think it's difficult. I think in the pediatric population, we're very fortunate because great care is taken about suctioning, suction length. So it's relatively unusual to come across it. So I think absolutely. So topical betnosol drops we do use. It depends on how big the granulation tissue is as well. Obviously, if it's totally obstructing, you wouldn't want to just give them betnosol, but betnosol is as the topical treatment. And you can either give nebulizers via the tracheostomy of steroid, or you can give drops down the tracheostomy tube. The other things to say is that you can use the tube length to, usually you would try to either be a little bit short, depending on the size, either a little bit shorter or bypass the granulation, go beyond it a little bit further. And that kind of depends on exactly where it is and how big it is. If you can bypass it, sometimes that's that's in the immediate sort of emergency setting, that's better. And then beyond that is going to theatre if nothing's improving, to try and remove it. So either cold steel or microdebride it, coablate it or whatever, to try and remove the granulation that's there. But it's something that it comes with trauma, and so that needs to be addressed even when you do remove the granulation tissue.
Perfect. There's another question which is more about tracheomalacia, and asking about how you'd overcome moderate and severe tracheomalacia apart from an adjusted tracheostomy tube if it is near the carina.
So, I mean, it depends a little bit about what the cause of the malacia is. So sometimes it could be external compression, which can be addressed with either tracheopexy or aortopexy. So those cases we usually discuss in our Airway MDT. In terms of a tracheostomy, obviously you have to be careful about going all the way to the tip, because forming granulation tissue at the carina is not great and very difficult to manage, and it's usually managed with ventilatory settings to try and open up and splint the trachea open and the bronchi open. And the other thing is stenting. I think it's difficult because you have to be in a unit where stenting is used on a regular basis. That can come with its own complications. So I think in some places they do stent the bronchioles and the bronchi where they are malasic, significantly malasic, but that can cause problems long term as well.
So the next question we've got is, how would you manage tracheostenosis post-tracheostomy?
Tracheostenosis, where at the level where the tracheostomy was?
I presume that's the question, that after following a tracheostomy, the tracheostenosis that can develop following decannulation.
So, I mean, I think that's where the airway reconstruction would come in. I'm certainly not an expert in terms of airway reconstruction. It would be something that would need to be discussed with an airway team, ENT team, in terms of what would be appropriate and the level of stenosis and how significant, how long the segment is, and what the options are. I think it would need to be on a case-by-case basis.
The next question that's come in is that what are the most common conditions in your hospital for which long-term trachea is done?
So usually I would say it's probably for the tracheovented kids, so children who require long-term ventilation, who require long-term ventilation on a long-term basis, so they remain tracheostomized even into the adult services. In terms of things like subglottic stenosis, and we usually try and find a sort of either reconstruction or the airway grows, so we try to decannulate those children. But as far as I'm aware, it's the tracheovented kids, often ex-prem, complicated.
And I tend to agree with you there as well. The next question that's come through is that, is there any difference regarding decannulation between adults and pediatrics in point of view of the steps of decannulation? So
I think in adults, certainly it's a lot less length of time of decan. The tracheostomies, even the short-term tracheostomies in pediatrics, are more long-term, if you like. Adult tracheostomies can be in for a very short period of time and then be decanned. And so the decan process is often much faster. They would usually do it over a couple of days, and they would just cap the tube and then take it out. There wouldn't be any sleep studies or anything else that would be done. So the process is much shorter and much less rigid, I would say, compared to the pediatric side. The pediatric side is a lot more set and lengthier.
Yeah. We've got an interesting question about reinnervation in vocal cord palsy, and what Rachel has asked is, in cases with bilateral vocal cord palsy, have you ever referred any patients for consideration of reinnervation with the decannulating?
So I haven't, but one of my colleagues has asked for an opinion from the centre. I think Southampton is the main centre that I'm aware of that does it, that's local to us. And yeah, so they would give an opinion as to whether that would be, as a possibility to decan, but I'm not sure of the success and how many, what their outcomes are or anything like that. But yes, certainly I'm aware that referrals have been made for that.
Yeah, I think it's also a service that's very much in its infancy.
Yeah.
Yeah,
I don't know what their outcomes are. I'm not aware of that, but I know that it's a centre certainly that's sort of pushing the boundary in terms of innovation. I'm not sure about bilateral, but certainly unilateral innovation.
And there's actually a very interesting talk by Mr. Yakubu Karagama, which unfortunately isn't in our archive yet, but hopefully will be soon, on reinnervation and the selection criteria that he suggests, even in pediatric age groups. So I'd suggest if anybody's got some time, when it's up, I'll put it up on our email as well. So the next question that we've got is, how can you assess for tracheomalacia, and what's your guideline for ruling it out?
So we would normally, obviously history and examination will be the two things. So history-wise, we would look for sort of cyanosis so worker breathing cyanosis when feeding or crying, being upset. We would normally MLB those children, so do a microlaryngobronchoscopy and have a look. We sometimes find that, and we would find it physically by looking, we would see that there is a malasic segment, which we would describe. Those cases are usually discussed in an airway MDT, and then a decision would be made based on what the malasic segment looks like. If it's pulsatile, if it looks like there's external compression, some children will end up with bronchoscopy and a CT to assess for any cardiac anomalies that are causing compressive symptoms. And in some cases, I think when we do the MLB, because we split the airway open, we sometimes have the impression that there is no malacia. But I think if I had a high index of suspicion that there is tracheomalacia, I would still ask for a separate bronchoscopy because they get a much more dynamic view than we do.
Yeah, perfect. I mean, just to piggyback off of that, I'd probably add, for everybody else's benefit, is that management of tracheomalacia is not the most straightforward and easy in the decision making, and there's usually lots of teams involved, at least at the Evelina, in deciding what and how to manage tracheomalacia, and when is tracheomalacia even needing management. Would you agree, Lily?
Yeah, I think it's a decision from the respiratory team, the cardiac team, if there is a sort of a cardiac anomaly, from the general surgeon. So we perform aortopexies, tracheopexies at Evelina. So it's definitely an MDT decision. It's not something from an ENT perspective that we would be expected to say unilaterally what to do with and whether to manage. But if the patient is relatively asymptomatic, even with a finding of malacia, we wouldn't necessarily go for intervention. We would just monitor them and make sure that they're doing okay in clinic.
Perfect. And the next, well, it's more of a two-pronged question. What's the youngest age for tracheostomy that I'm assuming they're asking that you've done or you've seen? And what's the most common indication in newborn tracheostomies in your hospital?
So I think in terms of youngest age, there's a large neonatal unit where I work, and there are lots of premature babies. We would normally wait until those babies are term, or at least 2 kilos if possible. And the reason for that is because there's a huge morbidity and mortality of putting tracheostomy tubes in neonates. So we would wait for as long as possible before putting a tracheostomy tube. But obviously that again would be something that to decide and discuss. There are custom-made tubes for younger children, but I think the necks of neonates are so small that there is a very large risk that the tubes can dislodge and come out. And sorry, what was the second question?
The second question was about what's the most common indication in neonatal tracheostomies in our hospital.
I think it's usually for ventilation because often they come with chronic lung disease of prematurity rather than any subglottic stenosis. I think later on, maybe subglottic stenosis when they come to clinic when they're a little bit older, but they're usually out of the neonatal unit. So usually the neonates is for ventilation.
The next question is about what's been your experience with tracheal thrush and how would you consider treating it in tracheostomized patients?
Tracheal thrush. So I don't have a huge experience. I'm aware of treating it around the stoma itself with topical treatment. Tracheal thrush, I have to say I don't know. I can find out and let you know, whoever you are. But certainly it's not something that I've come across or experienced.
And I think it's also not something that, at least in the past however many years we've been doing ENT, it's not an extremely common.
Yeah, I mean, would look for some, immunocompromise and things like that. There'll be other things that I would look for and make sure that I involve the infectious diseases team and so on. But it's not. I'm definitely not an expert, and I wouldn't be able to answer that. But I'm happy to find out and let you know.
And there's another question from the same gentleman who's asking about, would you depend on bronchoscopy or virtual bronchoscopy to confirm the diagnosis of subglottic stenosis?
So I'm not aware of virtual bronchoscopy. It's not something that we use as yet at Evelina. I think doing an actual rigid bronchoscopy, so rigid microlaryngeal bronchoscopy. I wouldn't use a flexible bronchoscope to diagnose subglottic stenosis. I would always fall back on the rigid scopes, just because I think the view is better and you can palpate the stenosis if there is a stenosis, and you can assess the length and so on. So it gives you a lot more scope to assess it formally, rather than just think with the flexible bronchoscope, you sort of bypass it very quickly.
And I think they've just followed it up with saying that they're talking about CT bronchoscopy rather than.
Yeah.
Just to add on to that, basically CT bronchoscopy is a great tool, but it does have the extra radiation exposure that we're talking about. Plus, there's a lot of volume averaging issues. If you've got really short segments of stenosis, you may sometimes miss them. So from our point of view, we usually do.
It's not something that I'm even aware, even for the children who do have CTs, that we would even look for that. We would normally rely on formal assessment in theatre.
I actually had a question for you, Lily. It's more about less of a question and more of just the thought process. And when you're talking to parents about decannulation, how would you counsel them regarding the time frames? I know you mentioned that there's certain time frames that you'd consider, but like right at the start, would there be something specific in your mind that you talk to them about?
Not usually. So so I wouldn't initially start. I would normally say we would expect the tracheostomy to stay for a certain length of time, let's say a minimum of length of time, I would say, rather than that time. So I would say the tracheostomy will stay at least for 2 years or whatever, or longer, or as long as they need ventilation or whatever. So I wouldn't normally talk about the decam process right at the start of the process. I think in terms of decannulation, it's important to talk about the prospects of it being successful, but also not being successful, understanding, what that will entail. Often parents actually who are used to having a child with a tracheostomy then feel very sort of nervous and anxious about having the tracheostomy taken away, because there's, it's a new challenge and a new, it's worrying. They're very used to looking after the tracheostomy and so on. So even that can be a challenge, and sometimes guided by them in terms of when to decan. Obviously, you want to decan as soon as possible, safely possible for the child, but obviously having the parents on board. So yeah, it's not, I would say I rely on my nurse specialist colleagues to have discussions about the decan process in more detail, but it's something that I would only talk about when I'm thinking closer to the time when I'm thinking about decannulation, rather than right at the beginning.